Hello everyone, Maria and
Gina Copelli
with Reflect and Reset with Maria and Gina. And you know that we feel that this is one of the favorite shows out there now live. What do you think?
Oh, definitely. I mean, we are like the number one in
Facebook. In my friends, a 7-Eleven South Broadway.
We're number one.
But as you know, all joking aside, we are here to provide information to all the followers, people that are following us. We're getting a lot of comments of how satisfied they are with the information that we're providing because we're covering every topic. It doesn't matter, like the medical marijuana doctor, Dr. Chin. That was an incredible show. And so the idea is to continue to bring you information that is valuable to you and the people that you know. So today we have one of my favorite guests that I know for a long time. I've had the privilege.
Yeah, so we have Dr. Marc Koch, who is the CEO and president of Somnia Inc. And as an anesthesiologist, we're learning that anesthesiologists are leaving the emergency room, not the emergency room, but the OR, to start practicing more of the health and well-being and longevity of their patients, because we know that, now with all the opioid epidemic and all the pain issues, and we're going to learn about a lot of things that he does in the private office to be able to help everything from depression, from pain management, which we'll talk about with this one. I'll tell you about that as we continue. But I'm going to let Dr. Koch introduce himself a little bit and give a little story about you. Sorry, as she's fixing me.
Sure. Well, I want to thank Maria. I've been a fan for almost 20 years.
Incredible.
And Gina, I feel it's a blessing to know you, and I consider you friend and colleague. So I'm just grateful, and it's a blessing to know both of you. Thank you.
Thank you.
And today I'm here to talk to you a little bit about how anesthesiologists are stepping out of the OR.
Right.
How they're playing a really progressive role in the health, safety, well-being, and even the longevity of patients in ways that when I was first practicing, I never even imagined. So I'm really here to help you share with your viewers a little bit about that and give a little taste of what we mean when we say that.
Awesome. So we're going to start because we like to share about ourselves, and I think people appreciate that. So Gina and I were at a weekend in my house in Vermont, and we took, there were 10 of us, 10 women, and we had an amazing, empowering weekend. And Gina and I went first, and we had our partners retreat. And we went skiing, and I ended up falling. And
the expert. She's the expert, okay? And she's putting me down black diamonds, which I made without falling. And I had to pick her.
Yes. So unfortunately, I am dealing with a herniated disc. And boy, it is painful. I have to say, it is. Yeah, it's very painful. And I've been blessed enough, to be able to have our facility here. We're doing physical therapy on me. I've taken the CBD oil, and I have to say that I am blown away. I've been suffering so much with this past few days. And yesterday, my partner came to rescue me.
My little medication. Yeah. I open your mouth under your tongue. Couple of.
And it was amazing. So I feel great. But aside from that, there are people that unfortunately suffer from this as a chronic condition. And boy, I feel sorry for them. But there are ways that anesthesiologists can help people with these conditions that are more chronic.
Sure. So, one of the biggest conditions that people suffer with that impacts their health, their well-being, their ability to work, be a great spouse or partner, mom, dad, whatever, is low back pain. And it's one of the most common conditions people suffer with. And nowadays there are therapies that can help people with all types of back pain, whether it's due to a muscle strain, it could be due to a malalignment, it can be done due to just about anything. And there are many therapies that you could use. For instance, one of the things people know is that just getting a good night's sleep, getting your sleep cycle tends to help people feel better. Walking, eating the right foods. It's not going to suddenly make your pain go from a 10 out of 10 to a 0 out of 10, but it all helps. And you exercise like I don't even want to know. I never exercise like you do. But even when I was 15 years old. You're amazing. You're really an inspiration. I can imagine how you must feel. Because
now I'm limited.
Can't work out.
Yeah.
I can't work out for at least 3 weeks. So
These guns are going to become very flabby soon.
Yeah, so Maria's a great example. She knew to start to walk, get some physical therapy, stay off of her feet when the pain got bad. And you're just a very wise, learned person. You know it. But for a lot of people out there, they don't know. And doing those things, the basics, that does tend to help.
But
did
it's
you
not
put
enough.
a block? How does it
Yeah, I was
work?
going to say, it's not enough to take her out of pain.
Well, you generally don't want to start doing a
That's
regional
for
block
really
right
chronic-
away.
yeah.
Because listen, epidural blocks is when you put a needle and you thread it through the space between your vertebrae and you give a little bit of medication, steroids, that tends to reduce inflammation and tends to make people feel better. It does, and it works fabulously. However, it has risks. Of anything, there's risks.
Yeah.
But sometimes having a little bit of Tylenol, maybe a non-steroidal anti-inflammatory, maybe a lidocaine patch on your back, resting, doing some structured physical therapy, a lot of times that really helps most patients.
Right.
Now listen, if you start having shooting pain down your leg and your foot drops when you walk and you're having problems controlling your bodily functions, then maybe it's time to quickly go and seek help with a person immediately, right away. Those are pretty big alarm bells, and that's a sign you want to crack the glass and pull the alarm and go see somebody.
Yeah.
But for people that have an acute injury that doesn't appear to be that severe, some of those non-procedural based ways can bring patients a lot of the way there to feel better and get back to life.
Yeah, that's what the orthopedic doctor that I saw, he said, this is going to take you, 4 to 6 weeks to really start feeling better. But I know, like we have one of our friends, Joe, that he suffers from chronic pain. He's had surgery, and he suffers. And I got to tell you that pain in your lower back, today, I was edgy this morning, and that's not me. I mean, I was saying, Gina, my house is a peaceful home. Like in the morning, my daughter's doing her thing, I'm doing my thing, we get together, we go to school. Today, I was so edgy. I could understand how people get angry, when you're so much pain.
They come in here looking for medication. They want the heavy stuff, and our doctors will not give it out.
It's part of, it's like life in general, right? You don't want to bring in the big guns right away.
Right.
You want to start with the minimalist approach, because maybe that works for most people.
Right.
And those that don't, maybe you do medications, a lidocaine patch, maybe something to help you sleep at night. And then maybe if that does non-steroidals, Tylenol, if that doesn't work, you can always do more.
Right.
Right? And your friend who's had multiple surgeries, that's called sometimes failed back syndrome, where you've had surgery, you've had these treatments, and they don't work. And those conditions are particularly difficult to treat. Yeah. And now they're looking at new approaches for that, such as stimulating the spinal cord, which has been around for a while. Trying things like ketamine for some patients might be helpful.
Ketamine. Can we talk about ketamine? Because we're learning about this
big subject here
recently. Mm-hmm. So talk about ketamine.
Sure.
And the advantages.
Sure. Well, ketamine is quickly becoming a leitmotif. It's something that is being looked at as a repeated, something that you would use for everything all the time. And I think we have to be very careful, right? The indications for it are evolving. Clearly, if you've had depression and nothing could seem to work, they've tried everything, this might be something to try. In particular, if some of your symptoms stem from post-traumatic stress disorder. Probably not a first-line therapy for everyone, because again, bringing those big guns right away, perhaps not. Similar in pain. There are pain, and I don't want to get too technical, but there's something called NMDA receptors, and ketamine works on those receptors. And ketamine has been shown in some patients to really help with those conditions. But again, not first-line therapy, not second-line therapy, but a therapy maybe when nothing else seems to do the trick and you're trying to find something. We have to be careful because, like anything new, everybody's trying to use it for everything.
Right.
Steroids are a great example.
Right.
Put them on your skin, take them by mouth.
Right.
Inject them in your vein, put it in your back. Everything could be steroids. right? And I think, again, there's indications. It's things that we would say, yes, it makes sense here. But it's not a magic pill. It's not something that should be used for everything all the time in any event. Because then you start to get complications, and then the very problem you were trying to solve gets worse, and then you have other problems.
You have other problems.
Right.
So is this something that just masks it for the pain, just so you can deal with it? Or is it something that actually helps somebody recover?
It really depends on the reason for your pain. Like maybe you have a bone spur that's hitting a nerve, right? That might require a different therapy. If your pain is something we call neurogenic, the nerve has been inflamed, damaged, irritated, it might be more helpful, for instance, some therapies might be more helpful for that.
Mm-hmm.
So again, you have to look at the etiology to the pain. Is it muscular? Is it skeletal? Is it neurologic? Is it psychological or psychiatric? And you have to approach it based upon the constellation of reasons why that patient is having that problem. If you try to look at this as back pain, ketamine, that would probably not be a prudential way to approach it, because you're probably leaving a lot of the tools off of the table that might have a better result with fewer side effects. Was that,
Yeah.
that could answer your question? Yeah.
So basically, then ketamine
Ketamine.
Ketamine.
is a treatment that will help people that have sort of exhausted every effort, right?
Yes. Yes.
So psychiatrists that are dealing with patients that are suicidal, is that something that they've tried different medications and for whatever reason nothing seems to work? This is someone that would qualify for a treatment of ketamine?
Well, I think it would be somebody that has refractory depression. No matter what they've done, how much they've done of it, when they've done it, why they've done it, nothing seems to work. And post-traumatic stress disorder, for instance, there are studies that show that this might be hope for people that have not achieved a good result with traditional means. But again, you have to work with psychiatrists.
Right.
You must. These are the experts of
Right.
these
Right.
conditions. And if you look at ketamine, it's a tool in the toolbox that psychiatrists can use. And working with anesthesiologists or CRNAs, they can find a way to offer that to some of their patients. But again, it's not for everyone. It's for a small subset that they as psychiatrists could determine
Right.
based upon the factors. You have to be careful, because there might be some patients where it's contraindicated. In other words, you don't want to give it. And those are the people that will help with the anesthesiologist or CRNA determine if it's one of those patients too.
Are there side effects to this?
Ketamine at various dose levels could have significant side effects. At higher levels, you tend to salivate quite a bit. You might have weird dreams or sensations or feeling a little bit out of your body a little bit.
Right.
And that is something that only happens at higher doses. At the lower doses that you need for depression or to treat PTSD, refractory PTSD and refractory depression, or you're treating pain conditions that don't seem to, lower dose, not the big doses where you would tend to see the side effects, but you have to be careful because every patient's different.
Right.
I mean, for instance, you're very fit and you're very, very in shape, but you can imagine if you had a very elderly patient who is very, very thin, a dose that for you would maybe help you with your refractory depression in that patient might cause a lot of side effects. And, that's not something you want to do. They could, if elderly patients, delirium and those sort of things aren't very helpful to them. In fact, they could be harmful.
So the treatment is where you do an IV drip, is that it? And it lasts for how long usually?
It really depends. I mean, the way you would do it is you would have a patient have the therapy, which is an infusion, where they put a catheter, tiny tube into your vein and give it to you with some fluid perhaps. And you typically will do that a few times a week, and then a couple times a week, and then see how the patient does and see if they need more. It typically isn't a one shot and we'll see you in a year. This is typically a commitment to try something because nothing else has worked.
Yeah.
And that commitment isn't a day, not a week, it's typically a 6 to 8 week commitment of your life to really try something new. It's also expensive. It's not like a Tylenol, which costs 50 cents or a quarter. This could cost some money, and you want to make sure that a patient understands that, and that you provide the means and mechanism for them to get that care.
Yeah.
Is this something that you, when you are a candidate for it, would, because I know that a lot of the psychiatrists, they put people on Zola or they go on Xanax.
Mhm.
Is this something that they would take hand in hand with this, or do they wean, is this something that could wean them actually off of that medication?
Yeah, I mean, those are decisions the psychiatrist really has to lead that discussion. Because you hit it right on the head, Gina. You know, this is exactly the issue. They could be on a serotonin uptake inhibitor, right? Instead, they might be on a tricyclic antidepressant. They might be on a sleep medication. They might be on medication because they have ADHD. All of these things are typically a palette of medication that's making that patient get to the best they can be, but not better,
Right.
not really functional. They really will decide what should be weaned and when, why, and how, because that's their expertise, frankly. And every patient's different, as you might imagine.
Yeah. Oh, interesting.
So I was just curious, you know, I'm looking at you and I'm like, why did you decide to go into anesthesia, to become an anesthesiologist?
Yeah, well, you know, I enjoy the critical care aspects of it. And actually, before I went into anesthesia, I had done a year of medicine, and I fell in love with seeing patients. I loved it. I loved talking to them. I loved learning about their families. I just loved it. But I also liked critical care. And I had spent a lot of my last year of medical school, and I had spent half of my medicine year doing ICUs. And there I was stuck. What do I do? They're so very different.
Yeah.
And I said, I'm going to do anesthesia because it allows me to do that critical care piece. And I said, well, maybe I could do pain, or maybe I could do something else where I get to know the patients. And as my career evolved, I found that I was continued to be drawn to that dialogue, that discussion, that engagement with the patients. And even today, that's really the driving force. When I get dressed and I go to work, it's really thinking about patients. And now I do a lot more thinking about population health and perioperative medicine, because I think really that's where the next frontier in anesthesiology and anesthesia will be.
So can you explain
Perioperative medicine.
Yes.
Right.
Can't
So-
say that.
So if you think about traditional anesthesia, we see the patient maybe a day before, maybe a few days before their surgery. We take care of them during their surgery. We typically might see them maybe a day after the surgery, maybe two. Perioperative medicine starts from the time the patient has been diagnosed with a surgical illness or disease until the time that they resume their activities of daily living or plateaued in their recovery. So if you imagine a bookcase, anesthesia is this, perioperative medicine is this. And the skills are very, very different. For instance, delirium, studies have shown that a patient who undergoes surgery, anesthesia, especially elderly patients, especially patients that might have a little bit of cognitive issues to begin with, if they get delirium, they're at a much higher risk to have steady progressive cognitive decline to the point where they may actually start to have signs and symptoms of dementia. So those are things that as an anesthesiologist, you might not have full awareness of that. But as a perioperative physician, you would say, okay, what could we do to minimize the chances of them getting delirium? What could we do in the weeks or even before to minimize the chance? What could we do to speak with our anesthesiologist or CRNA to make sure we avoid those things that could cause delirium, perhaps? What do we do post-operatively so we can avoid those things? And if it does happen, what do we do? That's the difference between perioperative medicine, for instance, and anesthesia. Another great example, pardon me, another great example is cardiac problems, right? We have anesthesiologists know, and so does CRNAs, they do a great job maintaining the blood pressure, keeping the heart rate steady, making sure that the patient doesn't move or have any discomfort and wakes up not recalling their surgery, right? That's what they rely on, and that's what they get, reliably and consistently. I feel so lucky and so proud to work with so many anesthesiologists and CRNAs, and they do a wonderful job. They're stewards of safety and security.
Yeah.
And you will get through this, you will.
I mean, you have people's lives. We think about the surgeon actually doing the surgery, and you think, they have the patient's life in their hands, but at the same time, I mean, you're driving.
Yeah.
It's like you're driving that surgery. The way that you were explaining it now, like I'm thinking, wow, it's a huge responsibility that you have.
Well, anesthesiologists working in concert, and CRNAs in concert with the surgeon together, and the nursing team, it's the triumvirate. That is the team. Together as a team, they do wonderful things. And the surgeon, their piece is huge, because without their doing their great work, nothing gets fixed.
Yeah.
Anesthesiologists and CRNAs, they have their piece. The nurses in the OR, often the unsung heroes, to make sure that the right things are done at the right time. The safeguards in the OR, I mean, they're wonderful. Everybody has a part to play. Perioperative medicine, though, is out of the OR too. Like they found, for instance, I thought this was so interesting. What they found is that patients after their surgery that had elevated levels of a specific chemical in the blood, let's just call it troponin. Troponin is one of the proteins, but that troponin, they find if you have elevated levels 1, 2, and 3 days out, your risk of having a cardiac event is much higher compared to if you don't. So here you are, maybe you're an anesthesiologist working with your perioperative physician, maybe you're just a perioperative physician, and you say, okay, I think I should get troponin levels on this patient. They're elevated days 1, days 2, and day 3, and they're elevated markedly. Well, what do? They're at a much higher risk to have a cardiac event. Right? So in the past, the question was, why do we get this test if we could offer the patients nothing? We just knew that they were at increased risk for a very significant cardiac event. But now new studies are being done that show that we could have patients take aspirin, take statins, which change the blood lipid levels, maybe go on an angiotensin converting enzyme inhibitor or a blocker. And we're starting to find out that we can actually change the course of patients' events, not the day after surgery, not the week after surgery, but the month and years after surgery, if we're thoughtful and complete in the perioperative care that they received. So that's an example of where anesthesia and perioperative medicine work very closely hand in hand. Otherwise, what happens is that patient doesn't have the most holistic approach to them and as a patient with all of their needs.
And closing the loop,
Thank you, Gina.
To close the loop, be able to have one doctor talking to the other doctor and trying to collectively work to help
Perioperative medicine, a lot of that is coordination.
Yeah.
Right? It's team building. It's finding a way to make sure that everybody knows what's important about that patient. If they're at high risk for delirium, everybody needs to know that. If, let's say, they have an event during the surgery where we think that they might have had an issue where we want to get troponin levels, somebody needs to quarterback that patient's care. And one of the big tenets of perioperative medicine is coordination of care, making sure that transitions of care are being managed. So if they show up at home with no follow-up, what happens?
Right.
Oh, they said that one of my levels was a little high. Did I need to follow up? I forgot. Right? Those sort of things can't happen anymore. As a perioperative physician, my view is that we need to think about new ways that we can engage, involve, and help patients through these transitions of care over the long term. Something we call, longitudinal outcomes, where we can really start to take a look at long-term morbidity, mortality, quality of life. And that's to me what it's all about. And it really gets back to where I first got into medicine, where talking and thinking about patients and their families and how we could help them get better, stay better, and be productive. It's back to where I first started, which for me is the biggest kick of it all.
Look, he's so excited. I mean,
you know what's funny? I was thinking, the reason we love him so much is because his passion is the way that we are. And passion is contagious. And unfortunately,
you're smiling while you're talking.
Yeah, a lot of people, I'm like totally interested in a topic that I would say a lot of people have a hard time following, because even the way that you're speaking, the language you're using, with your passion, it makes it easier.
Yeah.
To follow.
You know, my daughter is actually an RN at Montefiore Children's Hospital, and she's going to continue to nurse practitioner. She wants to be a nurse anesthetist.
Oh, fantastic.
Yeah, and
Great.
I said to her, and actually, you should probably talk to Dr. Koch and see his thoughts on it. And
I'd be delighted to, any chance to play a role in the education and information sharing. It's for me something I love to do. And whether it's a patient, whether it's a prospective person who wants to go into the field, to me that's what it's all about. We are so lucky now that we have data, reams and reams and reams of data. It could probably go around the moon 20 times. But how do we take that data and use it to help patients?
right,
Reduce their length of stay in the hospital. Make sure they don't get readmitted in worse condition, right? Make sure that longitudinally that their outcomes are great, where they don't develop cognitive decline, where they don't have fatal cardiac events, where they don't develop renal failure. This again to me is what perioperative medicine and medicine is all about. I've been very, very blessed to have as people who have taught me, people like Monty Mythen and Saul Aronson at Duke, and many people at the American Society of Anesthesiologists, Perioperative Surgical Home. But there are many other people out there that maybe they don't teach or they don't give the lectures, but who practice this every day. They're in the front lines as well and are doing the right things. And I think you're a big part of that because you're here. This is your facility. You're the front lines. When somebody comes in and they say, we need to see a doctor because we need to have our surgery next week, can I see them? Right? Well, you're at the front lines.
Yeah.
Right? Or do you have cognitive issues? Do you have cardiac issues? Are you susceptible to develop a prolonged issue with narcotics? You're at the front lines, and you have a vital role to play, not just as individuals, but as a facility to really impact patient health, longevity, and well-being. And I'm proud to know both of you. And I'm really humbled by the work you guys are doing because you're here at the front lines.
Yeah, we're really making a difference in our community, and I'm proud of, we were on Forbes magazine. You follow us.
Forbes.com.
Yes. We just got written on Forbes magazine, Forbes.com. And we are proud of that. And I got to tell you, the reason is that we feel so happy that people are recognizing the work that we're doing, because what we're doing is extremely impactful in our community.
Yes.
We are caring for the community that most people are not paying attention to, which is the people that don't have insurance. People, you have insurance, you have many choices. Although if you have the Medicaid products, you don't have a lot of choices. But, we can keep going forever. We're told that we gotta cut it. So we're gonna have to say goodbye, but Dr. Koch, what an amazing show. What a pleasure to have you. Can you tell us what your office, because we didn't say, did you say Somnia?
I did say Somnia.
Okay,
but
so
but
just tell us a little bit about Somnia.
So Somnia is a 24-year-old anesthesia and perioperative medicine company, and we provide services across the country in, I think, 15 states and growing.
Wow.
And again, our
We're
area.
gonna follow you in those 15 states.
I'll follow you.
Yes, because we're gonna go to 15 states.
There you go.
And for 24 years, this is what we're doing, trying to just improve the health, safety, well-being, and longevity of patients. And what was true in 1996 is true today. It's just there's more data, more tools, and a broader calling than we had when we first started. And it really is a blessing to know you and Gina, and to watch your mission and your values be manifest here.
Yeah,
And the role you played, it really invigorates me and excites me. Thank you for doing that. I feel very lucky.
What a show!
Sweetheart.
I hope you guys liked it, and if you did like it, please make sure you
On
like
social
us
media.
everywhere, all social media.
And
okay?
any questions, you know our number. Call us
Yes.
and we can hook you up with Dr. Koch or any of his doctors, so give us a call.
We are committed to you. Take care.
Thank you.
Bye bye. Thank you,
Bye.
Dr. Koch.
Thank you.
Of course, thank you.